Okay, we are set to go.
Perfect. So hello, everyone. I can see a few faces, so I really appreciate those of you who have your cameras on. It makes it feel far less lonely giving a presentation about ethics when you can see other people. But I also appreciate this has been a challenging last couple of weeks, and some of you may also be feeling there's a little bit of Zoom fatigue and may not want to feel like you're on camera all the time. So please, by no means feel you have to keep your camera on all the time or anything like that. So my name is Michael Van Manen, and I'm the director of the Doster Health Ethics Center here on campus. I'm also a physician. My specialty is in newborn intensive care. So I have the lovely job of taking care of babies for a living. So you'll see me draw a little bit on that clinical experience in giving this presentation today. I did send out the slides to Kim, so I'm hoping you have them in advance.
Yep, they have them on eClass. Yep.
Oh, perfect. So whether they're helpful to you, certainly if you have any questions during this presentation, jump in and interrupt me. Just because we're using PowerPoint doesn't mean we have to stick to the PowerPoint, nor do we have to stick to some order of the slides. It's always much more fun when other people are talking than just me. I put on this first slide the link to the Doster Health Ethics Center. We have a number of seminars and workshops through the year. We really welcome and encourage students to attend. If you ever find any of our events have a cost associated with them and cost is an issue, just email me and we'll certainly waive the costs because we want all of our offerings to be accessible, particularly to students. So I'd like to begin just by having you all reflect. I don't want to put anyone on the spot of having to reflect in front of everyone else, but still just think about these questions. How do you understand the meaning of ethics? What do you see as significant ethical questions for the future of medicine, or for the future of Canadian society, or for our global society? How do the ethics of technology relate to the ethics of medicine? Are they one and the same thing? If they're different, how do they differ? Do we anticipate the qualities that exemplify what makes an ethical nurse, physician, social worker, or other healthcare provider to change over time? Do we understand what those qualities are right now? Do they differ between different disciplines of health? What is the role of ethics in clinical practice, in healthcare technology design, in innovation, in research? These are all questions that we could spend time talking about today, but just spend a moment thinking about them while I sip my coffee. These are going to be the so-called take-home points I'm hoping you're going to get from today. And we'll go through each of them in turn. But I wanted to kind of jump in to a clinical situation. So as I mentioned, I work in newborn intensive care. And one of the reasons I chose to work in the specialty of NICU is that we very much have a history of dealing with ethical issues, of our discipline having, you could say, an ethical discourse around decision-making before a baby's born, about resuscitation at the limits of viability, of asking, what technological interventions are too much, what are required, what is enough, what is the meaning of quality of life, how significant are different outcomes like disability and counseling and making decisions. So we've been constantly confronted with these kind of issues. And although we've been confronted with them since the beginning of our specialty, these are still very much contemporary issues. So I want to read out this little anecdote, which comes from this really nice article by Annie Janvier cardiac surgery for children with trisomies 18. And I recognize that some of you do have a medical background, others don't. So I want this to be understandable to all of you. So Daniel, during their first pregnancy, Simone and Gregory Alterbach were told the first trimester screen was abnormal. So all people, when they're pregnant, they're offered the opportunity to have screening tests done to identify whether there's anything unexpected about their child. And the first trimester screen is generally a combination of various blood work that's performed that tells you whether you're at increased risk of having a child who has a significant genetic abnormality, and in particularly aneuploidy, which is a different than normal number of chromosomes. And I hope you can see I'm struggling to find the right terms for this. So the diagnosis of trisomy 18 was made at 15 weeks after an amniocentesis. So that's putting a needle in through the belly of a woman and taking a sample of the amniotic fluid around a baby and essentially sending that for a chromosome study. And the finding of it was trisomy 18, which means an extra copy of the 18th chromosome. The couple decided to continue the pregnancy and named their unborn son Daniel. What does it mean when you name a child before they're born? What does that call forth as far as their identity? The bad news continued, coming with every appointment. So the author of this anecdote has qualified trisomy 18 as bad news. Daniel had esophageal atresia, club feet, and the latest heart ultrasound showed a severe form of hypoplastic left heart syndrome. Now at 31 weeks of gestation, Daniel only weighs 900 grams, showing no fetal growth in the past 2 weeks. Oh, I thought I put some little pictures here. 1 second. Oh, I did. So again, just to make sure we're all on the same page of discussion. So esophageal atresia is when there's a disconnect between your esophagus and your stomach. So essentially, normally when you eat, food goes into your mouth, goes into your oral pharynx, your oral cavity, and then passes to the back of your throat. And normally when you swallow, it goes down your esophagus into the stomach. But in esophageal atresia, there's a disconnect. So if you try and swallow, food sits in a little pouch, a blind end in the esophagus, and then makes its way into your lungs to obstruct your airway. And then some of it might get into the stomach, but more aptly, you'll reflux stomach juices into your airway as well. So this is a condition that's incompatible with life unless it's surgically corrected by essentially dividing this connection and bringing these two ends together. The other condition in this story is hypoplastic left heart syndrome. So this is a diagram of an abnormal heart. So blood comes from the body through the superior vena cava and the inferior vena cava. This blood is blue. It hasn't been oxygenated with blood. It sits in the right atrium. Atria are waiting chambers for the heart, so that's where blood gathers. And then it goes into the right ventricle to be pumped into the lungs. That works okay in hypoplastic left heart syndrome. So the blood makes its way to the lungs and comes back to the left side of the heart, to the left atrium, where again it sits and waits. But unfortunately, the blood can't make its way into the pumping chamber of the left side of the heart because it's hypoplastic. It's not appropriately formed. So blood can't get out to the body. The only way for blood to get to the body is there has to be a connection between the two atria. So blood from the lungs and blood from the body ends up mixing together and it's pumped out again towards the lungs. That still doesn't solve the problem of blood getting to the body. So these babies have to have an extra vessel, this patent ductus arteriosus, that would normally close after birth but needs to stay open for blood to get to their bodies. Over time, this vessel would naturally close unless medications are started. So again, this heart condition is also incompatible with life unless surgery is done. Now, surgery can't fix this heart condition. There's only really two options. One is to get a heart transplant, or the other is to do a series of surgeries over a child's first roughly year of life, where the vascular connections are redone to essentially come up with a functioning pumping chamber that delivers blood to the body, yet also still perfuses the lungs. And we don't need to go through the details of that, except to say that babies who require hypoplastic left heart surgery do spend a significant amount of their first year of their life in hospital. And although that's a surgical condition that now has much higher survival than in the past, there are some babies who suffer complications along the way, and babies who also pass away. Well, what about trisomy 18? What is that? So I mentioned already, trisomy 18 is one of the most common aneuploidies. An aneuploidy is a difference in chromosome number that's other than expected. In the past, when Kim was a medical student years ago, trisomy 18 would have been described as a universally lethal condition. When I was a medical student, not as many years ago, it was described as a lethal condition. It was recognized that most babies with trisomy 18 die in the first week of life after they're born if they don't die during the course of pregnancy. And for those babies who pass away, it's either because they simply don't have the drive to breathe, or it's a consequence of an underlying heart malformation as the most common cause. And as you can see, it's not just heart conditions that babies with trisomy 18 have. They can have limb abnormalities in how their brain is formed. I showed you an example of a gastrointestinal anomaly. They can also have abnormalities of urinary tract as well. So what does this mean? Most of the time, when someone comes in pregnancy and a diagnosis of trisomy 18 is expected, suspected, or otherwise identified, the option of ending the pregnancy is provided. So what are we talking about? Pregnancy termination, right? Therapeutic abortion. We have different words which carry a different moral sentiment towards those activities. And if you were to just Google trisomy 18, you would see these kind of pictures, which carries that same kind of understanding of trisomy 18. That look, this is a genetic condition. It affects every single cell of these babies' bodies. It's very sad, but there is ultimately no cure. Treatment shouldn't be provided, but rather the focus should be on keeping these babies comfortable after birth or ending the pregnancy to so-called spare the parents the pain of delivering a child who's going to pass away. But if you also keep on looking on Google, you'll see something else. You'll see the National Trisomy 18 Awareness Day. You'll find Facebooks for around trisomy 18, support groups for families expecting a baby with trisomy 18. And you'll quickly read stories about individuals who describe situations of having to advocate for, fight, or otherwise almost have confrontational encounters with the healthcare system because they want some intervention done to keep their child alive. Because the reality is that if you do heart surgery on babies with trisomy 18, if you do fix the tracheoesophageal fistula, most of these babies don't die in the first week of life. Many of them do survive, but their survival depends on what you're prepared to do as a parent, meaning the decision maker, as a healthcare professional, whether you're a surgeon or a medical doctor or a neonatologist. It depends as a society how we're comfortable using our resources, right? Knowing that some of these babies will be in hospital for their entire life potentially. particularly in a time when we may be short on intensive care or other hospital resources. There are now guidelines, basically here's the different things that as a physician you should look out for, or otherwise engage in order to assure good health care for babies with trisomy 18. And families who are now contemplating decision-making around trisomy 18 are faced not just with the face of their own child, but they're also faced with some of the stories of these children as they've grown up, and the realization that with the utilization of medical technologies, these children can have a so-called good life, a life where they communicate or interact with others, maybe in a different or another way than we're interacting right now. Not all of them have speech, but that doesn't mean that they themselves don't have moments of joy, and that they also give moments of meaning to their family as well. So this is very much a contemporary ethical issue for neonatal intensive care. How ought we to practice? Do we practice in a way whereby, we use whatever resources we have for the patient in front of us, recognizing that resources might be limited, but we need to advocate for the child in front of us now? Or do we take a step back and say, what are we trying to achieve within healthcare? So this is the nature of ethics in NICU and in medicine, that actually, unfortunately, doesn't necessarily get that much dialogue within broader society. So if you think I'm coming up with this as a fictitious case, I can say that I've dealt with 3 of these babies in just the last 6 months, right? And each of them required a great deal of hospital resource use, divided different physicians and nurses around, are we doing the right thing? And from an ethics perspective, you can say, well, what is ethics? What is the purpose of ethics here? Ethics is about trying to open up different understandings of a situation. It's about raising different kinds of questions. So some people understand ethics in a very narrow way of saying, well, the question should ultimately be, going back to that little anecdote of Daniel, should we or should we not resuscitate Daniel? And in fact, if I were to show that anecdote to many of my colleagues in neonatology, the first question that they would be wondering about, is this woman going to be delivering? The baby's not growing, right? The baby might have distress. Are they going to talk about, trying to do heart surgery in a baby who's weighs, just around a kilo, knowing that the outcomes are very guarded. But there's actually much more to the ethics of this situation. So we can phrase such questions like this. So what are the ethics expecting a child with a genetic difference? What might it be like to receive a prenatal diagnosis? What is given in a diagnosis? How does it mean to conceptualize a genetic difference as a disorder? What are the ethics of being a healthcare provider in such situations? What role do healthcare professionals have in decision-making? Should doctors simply offer decision makers choices, meaning it's up to you? Or should they offer recommendations? Should they be stewards of healthcare resources? How do we navigate personal, religious, fiscal, social, and political perspectives in medicine and healthcare? Just yesterday, I was talking to a colleague in health law around the triage protocols that are in the media right now around COVID-19. And in phase 1, it talks about no longer admitting people to the ICU with dementia. And she asked of me, Michael, why do we admit people to the ICU with dementia? Right? So, it's actually that ethical question of, well, what is the role of intensive care in someone who's actually approaching the end of their life? What are the ethics of healthcare resource use? What is the role of anticipations of lethality and futility in such situations? How do we come to terms with the significant healthcare resources that children with medical problems are afforded compared to those with so-called social problems? So there are children within Edmonton to this day who go to school without lunch, who go to school without having the opportunity to have eaten breakfast, right? Who live in significant poverty, right? There are Canadians who don't have clean drinking water. And yet we spend tens of thousands, millions of dollars on children who have a medical diagnosis, right? What are the ethics of inaction and inaction? Is it the same not to do something compared to do something and then stop? What is the meaning of doing nothing as a parent? Is one a good parent when one so-called does nothing? What does it mean to be a good doctor? Is being a good doctor the same thing as being a good parent or a good nurse or a good respiratory therapist or a good social worker? How do each of these professions have their own sense of virtues within their field? What are the ethics of orienting towards a cure? Does a cure betray a normativity bias, an ableist bias, whereby somehow a life that may be afflicted with a syndrome or an anomaly or some other health condition is valued as a lesser life? What role do we see medical care having in supporting not just life, but also living, or living a life of meaning? So I don't know if I'm just coming across as rambling on at this point.
Nope. It all seems cohesive. Yeah.
But my point in kind of opening this way is I wanted to throw you in the thick of it, because this is healthcare. This is ethics nowadays, right? This isn't something theoretical. These are our day-to-day decisions around how do we use not just the technologies we may have in the future, but how do we use the technologies we currently have now, right? And the ethical implications of those technologies are not really realized from an armchair. They're realized in the thick of it, right? In those concrete, actual moments of engaging in care with babies, with families, right? With patients. Any questions about that before we go on? I'm going to try and stay organized on my rambling, I promise. I wasn't on call last night, so I have no excuse.
Oh, I think you're doing fine. Yeah, the students in the room don't look like that they have questions.
Okay. Feel free to use the chat if you're feeling shy. So first take-home point. Ethics is always already present in our day-to-day interactions. So if I'm going to make this point, I do need to actually articulate what is ethics. Anyone have any thoughts? How would you describe ethics?
Yeah, you want to pass the mic over? You don't have to be right on top of it, just sort of close, but you don't.
There's a switch at the top, just push it up. Yeah.
Okay, hello, can you hear me?
Yes.
I can hear you perfect.
Great. So I think ethics is a code of a way of behaving that we follow in order for society to function. Yeah.
Perfect. Thank you for putting yourself out there as the first person. Sean Lee, what do you think about that? Sorry, is it Sean Liss?
Lists, yeah. I view ethics as a codified system of morality by which action can be taken.
Perfect. Thanks, Sean. Anyone else? Samadhi, and I'm sorry if I mispronounce the name. Can you correct me?
It's all right. It's Samadhi.
Samadhi. Okay.
Yes. I think ethics is a complicated question. I'm actually in an ethics philosophy class right now, so like I'm kind of confused as well. But currently, I would say, how do we approach people and how do we approach different people? That's how I would define ethics. It's kind of still vague, but I think the vagueness is necessary because if we can't answer that question, then we're excluding some people, I feel.
Yeah. Any other thoughts?
Hey, yeah, I just had, I guess from the medical perspective, I guess it's just the balancing act between patient beneficence and also practicing non-malevolence as well. So doing right by the patient, but also balancing that with how your actions may be actually negatively impacting them. And then I guess also like patient autonomy and patient justice as well.
Perfect. Thank you. We have a principalist in the audience.
Yeah, and Andrew Archibald says the pursuit of knowing what is right or wrong with respect to acting or behaving in situations that involve others. Perfect.
This is great. I can go home, but guess what? I'm already at home. So, honestly, there's not a single definition that people provided that isn't a correct definition. All right. I don't think there is one agreed upon definition of what ethics is, to the extent that it actually has become a philosophical problem for philosophy as well as other disciplines. And it becomes a question. It makes a question of itself. What is ethics? Why is the discipline of ethics needed? And I guess how I approach ethics, or how I understand it, is we have a discipline called ethics because there are these situations that can't be simply resolved by appealing to some kind of a code. We have these situations that can't just be resolved by reason or calculation. Even if we do appeal to a code, say to some principles like we're mentioned, like respecting autonomy and beneficence and non-maleficence and justice, we also have to ask, why are those the right principles in which to follow? How do I deal with those situations where principles conflict? How do I weigh one principle compared to another? The other part of the definitions that were provided by people that I really liked is ethics is concerned with otherness. And from that perspective, it is a socio-cultural phenomenon in the extent that, why do we have ethics? Because we have to live in a world with people other than ourselves. We have to somehow navigate a social order. And the reason that we have health ethics is because people who work in health, whether you're a doctor, whether you're a nurse, whether you're a social worker or some other health professional, we're confronted with caring for people other than ourselves, who may have different values, who may have different expectations, who may have different needs and different wants. Right from the beginning of life, as healthcare professionals, we are engaged in acts of otherness. I like this picture. This is from the NICU. It's a baby I took care of. For me, neonatology, one of the reasons that I find this discipline is fundamentally about ethics is because this patient who we're ultimately responsible for is someone who's coming into the world. We're making decisions for babies who parents may not have had a chance to hold. This was the first day that this dad held his daughter. She's 6 weeks old in this picture because she'd been through multiple surgeries before. Right? Parents are routinely put in situations of having to make decisions for their children based on ultrasound or other technologies. How does a parent come to know their child? How do these technologies shape this person who's other to us? And we also have to ask the question of, how does this other little person who we're responsible for grasp the world around him or her? And through the course of an individual's lifespan, people's cognitive capacities change, right? This is a picture, I think, originally from the Alzheimer's Society. That's where I got it from. You know, what kind of existence is that like? Ethics has to deal with situations of making care decisions for people who may have a different existence, in the sense of, yes, they have moments of contact. Yes, they may have moments of joy and pain. But what's it like to live a life where you're no longer able to form new memories? What do we understand as the meaning of a memory when something is familiar, but you can't put a name to it? Well, this is just a picture of ethics, right? You know, in a course like this, where we're talking about, you know, the possibility of a technological singularity or other entity, how is it going to look on us? How will it treat us as someone other to itself? How do we engage and treat others to us on this planet in which we dwell, right? How do we treat, you know, whether we're talking about cattle, so-called livestock. What a weird phrase, livestock, something that's living that we're taking stock of, right? As if it's a commodity, right? What are the ethics of animal research, let alone the kind of treatment that we engage in animals? This is ethics, right? The moment we're asking questions of how we act and our actions impact upon others, that is ethics. I'm sure many of you are following what's happening in Texas, right? I'm not even going to go there. But we can go here. We can go north of Edmonton, right? Is this ethics, right? Does our land have some kind of a subjective existence that's just so other to ourselves because we can't fathom it having a consciousness? And yet, how do we treat it? You know, as a resource for living? What are the ethics of it, right? And my apologies if I'm coming across too quickly with some of these points, because honestly, there's other perspectives to this, right? I know there are many families who, you know, are dependent on, you know, living off the land, or, you know, being engaged in the oil sector and industries for their livelihood and the care of their families. But ethics is always about looking for other perspectives, looking for a perspective other than your own. I love some of these like futuristic shows, whether they're on Netflix or Prime or Amazon or whatever, right? Trying to imagine futures of otherness, right? Trying to imagine how these new others would relate to us and how we would relate to them, right? You know, when I think about the Matrix movie and then I think about livestock, right? You know, why do we feel it's so unjust in the treatment of humans as far as how we treat other animals in our planet? So what is ethics? This is a graduate level course. You're all allowed to have different perspectives than me. And in fact, I welcome it. But if someone were to put me on the spot and say, Michael, can you tell me what ethics is? I would say ethics is founded in this concern for how we act in response to whom or what is other to ourselves. And that speaks broadly to environmental ethics, to healthcare ethics, to technological ethics. You can't have an ethical question without a regard for someone or something that is other. Thoughts about that? Is this resonating with you? Is this something you agree with? Is this something you're like, no, Michael, you're full of crap? Because I'm okay. I like hearing that. I love Emmanuel Levinas. Love him. That's a very strong word. Levinas was a French philosopher, And in his work, he tried to get at phenomenologically, well, what really is the meaning of ethics? And for him, ethics isn't understood in codifications of behavior. Ethics is rather found in this relationship, in this encounter with what is other to me. So for him, ethics isn't optics. It's a way of seeing, but it's a way of seeing without image. So what does that mean? It's a way of responding to the world around us without reducing the world around us to some kind of a concept or something that otherwise is reduced to my own subjective grasp of it, right? So for loving us, we have to keep what is other, but not altogether so other that it's completely other than me. But as was mentioned by others, ethics also has a normative sense to it. So when we start talking about ethics, words such as good and bad, right and wrong creep in. That's what I mean by normative, right? So ethics is also the inquiry into what is valuable or into what is really important, the inquiry into the meaning of life or into what makes life worth living or into the right way of living. So for a course on the future of medicine, this is really a course on ethics, right? It's a course on how do we respond to this world in which we dwell, this world that is changing around us. What is valuable to us now? What is going to be valuable to us in the future? Knowing that our subjective reality is likely to change, as is the reality of those around us. And we may be encountering other beings, including ourselves as others, depending on how we choose to redesign ourselves or what technologies we choose to make a part of our own bodies and our own lives. So my first point, ethics is always already present. I see ethics everywhere as a healthcare provider in every discipline of medicine, right? And I also see ethics in the classroom when students are engaging with their, when teachers are engaging with their students, right? In businesses when, shopkeepers or other agents are dealing with their customers. I see it even in our politicians, right? When our leaders are dealing or we're somehow responsible or responding to the public that elected them. Okay. Questions, thoughts about that? All right. The proto-ethical question asks, what is going on to which I must now respond? Oh, am I going to do this? Am I not going to do this? Why not? I need a break. So I'm going to show you guys a quick little video. Sorry, 1 second. I'm not quite as smooth as Zoom as I'd like to be sometimes.
Just imagine you wake up one day with the feeling that something isn't right. Where on earth am I? Is this man next to me? And why are there tubes connecting me to him? A doctor explains your situation. The man next to you is world famous. He is a virtuoso violinist. But his life is in danger. He suffers from a fatal kidney disease. He's been waiting for blood for days, and time is running out. But then, yesterday evening, a few of his biggest fans brought you to the hospital because you are the only person who has the exact same blood type as he does. Connecting your two circulatory systems is his last chance. Otherwise, he will die. You, and only you, can save his life. What? All of a sudden, you remember, last night the violinist's fans kidnapped you and brought you to the hospital. can hardly believe it. They kidnapped you to save the violinist. You try to free yourself from the tubes. Get me out of here. But the doctor tries to explain to you. As soon as you pull out the tubes, the violinist will die. You will kill him. You can't do that. She tries to calm you down by assuring you that the therapy doesn't last forever, just 9 months. Then the violinist will be restored to perfect health, and you can go home. So what do? Do you pull out the tubes? Or do you stick it out in bed for 9 months? What's more important? The violinist's right to life, or your right to self-determination? Some philosophers see a similar dilemma with the termination of unwanted pregnancies. Pregnancies because contraception failed, for example, or even as a result of rape. The life of the unborn child depends on the pregnant woman, like the violinist's life depends on you. And assuming the unborn child already has a right to life, the question is, which right is more important? The fetus's right to life, or the pregnant woman's right to self-determination?
Dun, 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 dun. Sorry, one sec. Back into this. Jumping around. Look at that. We're back in PowerPoint. What do you guys think of that?
I like that video. I think it was a good analogy.
Okay. Other thoughts? This is really common in the kind of field of health ethics, coming up with these, weird and sometimes crazy scenarios, right? Oh, someone has a microphone. What are you saying?
Oh, I said, well, the thought experiment sort of mentioned that he was like a world famous virtuoso violinist and he had like tons of fans and stuff. That sort of implied that his life somehow had more value than a baby's who was unborn and still, as of yet, has an undetermined future.
Yeah.
So I guess that also factors into it.
Oh, Seanless?
One thing that was kind of omitted in terms of things to consider when they made the comparison to, say, the unborn baby was they didn't really talk about the quality of life of the person considering that option, whether they want to carry it out or not, and how that would affect the rest of their life.
Thanks, Sean. Samadhi?
I was basically going to say the same thing, where like pregnancy kind of it changes you. And like when you do give birth, it's a traumatic experience to the body too, especially if you don't want it. So like I think it's a lot more, again, complicated than the video showed. Yeah, kind of boiled it down a little bit.
Any other thoughts?
Yeah, I didn't really like the analogy between the two cases. I mean, I thought there was also some kind of virtue signaling between the two. And because I think, the average person would, if they were in the situation where they were connected to the violinist, they would probably, stick out the 9 months. But to then imply that would be the same case for a pregnancy, I think is a bit of a oversimplification.
Honestly, I sometimes refer to these kind of thought experiments as almost like a quandary ethics. They're really interesting to watch and they often get you thinking, but ethics is so much more complicated than that. And this is already quite complicated, right? So the ethics around, pregnancy termination or abortion, sometimes it gets reduced to you're either pro-choice or you're anti-choice. You're either, pro-life or anti-life, right? But there's so much more to it than that, right? Like, how is it that, we find ourselves responsible for a baby before we've even felt them, right? What is the nature of ultrasound as far as making a baby present to appear as an individuated being from its mother, right? You know, what are the differences in tension between making decisions around someone who hasn't yet lived a life and one who has lived a life, right? So there is so much missing from here. And to be honest, usually when we're actually faced with very difficult decisions in clinical practice, it's those concrete details that actually help to navigate through a situation rather than being placed in some kind of impossible decision. But I would still encourage you that if you're interested in ethics, that, you know, some of these classic thought experiments, and I know Kim was going to email out or put some resources around the trolley problem on to think about. You know, these are great ways of introducing yourself to ethics or thinking about different perspectives to take in a situation. But thought experiments ultimately are just that, they're thought experiments. But the real life situations that we have to deal with in clinical practice are more complicated than any kind of convoluted thought experiment might be. There's so many of these nice little videos on this hashtag Philosophics. So please, you know, at some point when you're just sitting there and you're thinking about watching a YouTube video of a cat, watch one of these instead. I guarantee they'll make your heart and head kind of hurt a little bit. So the reason that I would say this is like the proto-ethical question is when we're faced with ethical decisions in clinical practice, one of the best ways of approaching the situation is not to ask, what should I do? But rather to ask, what's going on to which I must now respond? What might this decision be like for this parent? What might this decision be like for this patient? What might it be like for the nurse or for the surgeon? And once you start to open up different understandings, different perspectives of a situation, yes, it gets more complicated, but you usually begin to be able to find a path of working your way through it. And you ultimately realize that your own perspective is just one in a manifold of others' perspectives. So ethics isn't about seeking compromise. That's not the right way of thinking about ethics. Ethics is about opening different perspectives and then hopefully thoughtfully weighing them. I wanted to talk a little bit about the idea of moral consciousness, because I think I'm hoping for the second section that we do together, we can focus primarily on ethics and technology. But there's sometimes a discussion in some of the technology literature that I've read around the idea of machine consciousness, and would some kind of technological being have a regard or a caring regard for who we are, right? So some researchers have tried to better understand this notion of moral consciousness, and I just pulled some quotes from some of the writings. I'll just let you read that on your own. So the idea around moral experience. So what do I mean by a moral experience? A moral experience is an experience essentially where we start to make a judgment of something being right or something being wrong. And this comes from a nurse researcher, Franco Carnevale, who's from Eastern Canada. And he writes about moral experience as a subjective experience. And it's also hermeneutic. So subjective means it has a perspective to it, and hermeneutic meaning it's interpretive. So it encompasses a person's sense that values that he or she deems important are being realized or thwarted in everyday life. So when you understand moral experience in this way, you can appreciate how, depending on the values that you were brought up to cherish, the values you were brought up to value, different situations are going to potentially appear morally good or morally wrong based on how you interpret them from your own perspective. So if we think then about, the idea of a technological singularity, we would have to ask, what kind of a subjective grasp could a machine have of the world? What kind of sense making would it be capable of it, right? What values would we give it? This is some writing by Calvin Schrag, and he wrote about the structure of moral experience. And again, it's coming out of the more continental philosophy literature, so more phenomenology and existentialism. So for him, moral consciousness is structured by an intersubjective intentionality. So what do we mean by intentionality? This is our directedness towards the world, how we experience the world around us. Why it is that when I walk into a room, I don't experience that room as just simply a confusing array of light and shapes, but rather I make meaning of it in the sense of, I don't see a surface with 4 legs, I see a table, right? So for him, our moral consciousness works in the same way. It's structured by an intentionality, which inherently is embodied, right? And as a consequence of our bodily relationship to the world, which begs the question for any kind of technology that would be developed, what would its embodiment entail, right? Particularly if it reached the point of having an intersubjective or subjective relation to the world, which is so different from our own. The moral self is a historical self. So to exist historically means to be in a process arriving from a past and moving into a future. So we can't actually really live in the past. We're always making sense of the past in the present, right? And the present that we have in a moment anticipates a future, right? This is in part why the idea of, I'm forgetting the word, someone might jump in and be able to help me, in that TV show Westworld, right? When the machine started having, remembrances, or I don't remember the little word that they used, that was in a way a moral awakening, right? Because of the capacity to actually reflect on a past, right? To exist in more than just the present. And really to have any sense of time, one has to be able to appreciate more than the present. Moral experiences have a retentional character tied to past experiences. So it's not just that the present comes from the past and anticipates the future, but there's something about the past that is retended, right? I mean, held with, that bleeds into the present, just as the present bleeds into the future, right? To exist morally is to live with purpose, right? So what is purpose? Purpose is a compelling element in some future living condition. It's something that we anticipate, something that we may strive towards. And this thing that we live towards has some kind of meaning to it, right? Whether that meaning is a sense of justice, whether that meaning is a sense of happiness, there is something that, we qualify as good because we live towards it. And yet that at the same time, our sense of moral consciousness is not one that is infinite, right? There are limits to it based on our own apprehension of time and our own apprehension of space, which becomes quite an interesting point to make philosophically if you then consider, well, what if technologies had very different limits to those imposed by our own grasp of reality? Now, I wanted to go through really briefly through some different kind of moral perspectives. And the reason for doing that is to coming back to different people's grasps of what is ethics. And I'm hoping by pointing to some different moral perspectives, people will appreciate just how varied and rich the discipline and traditions of ethics and morality are. So in some ways, some of the definitions that were provided around what is ethics could serve very nicely to what is a deontological perspective of ethics, or what is a consequentialist perspective of ethics. My reason for going through them with you is also to understand they have heuristic value. And by that, I mean, when we're making decisions around, what should we do in contemporary healthcare practice, or how should we design certain technologies, or what should we anticipate in the future, we can look at those situations through different lenses, through different heuristics, different ways of questioning what is good, or what is right, or what is wrong, and what is bad. So one perspective of locating what is good is known as a deontological perspective. And deontology comes from the Greek deon, which means it expresses obligation, that which is binding or duty. So deontological perspectives of ethics are also known as obligation, duty, or rule-based ethics. So classic examples of deontological ethics are found in codifications of ethics, right? So you can think of the Decalogue, the Ten Commandments, the sayings, where there are prohibitions and prescriptions on how to act. Thou shalt not kill, honor thy father and thy mother. So whether your action is right or wrong depends on whether it abides by thou shalt not kill, whether it abides by the rule, the duty, or the obligation. Okay. Now, what rules, what obligations should we follow in society? So Immanuel Kant's famous kind of first formulation of the categorical imperative is basically act only to the maximum whereby you can at the same time will that it should become a universal law. In other words, those rules or those obligations that we would want others to follow in the treatment of us are the rules and obligations that we should follow in our actions that impact upon them. Does that make sense? Now, in contemporary bioethics, we have these so-called principles of biomedical ethics that come from the writing of Beauchamp and Childress. And they were referred to, I forget by which person, whereby a moral action should be one that does good, so beneficence. It shouldn't result in harm or non-maleficence. It should respect the independence of the patient, autonomy. And it should be equitable, not just for the patient in front of me or other groups of patients who might have similar conditions, but also for society at large. And that's the notion of justice. So we have lots of examples of codifications of ethics, such as the Canadian Medical Association Standards of Practice, and similar ones exist for the American academies and other places within the world. But what all of these kind of perspectives or this kind of way of looking at ethics has in common is this idea that ethics or the morality of action is realized based on whether it conforms to some kind of principle or rule, which is quite different from a consequentialist perspective of ethics. So consequentialism takes the consequence of an act as the ultimate basis for moral judgment, right? So the action that results in saving the most lives, right, is going to be the one that is going to be right, right? So we can see a consequentialist perspective enacted in our triage protocols around COVID-19, or the mandates for public health restrictions, right? And the choices that are made to maximize healthcare resources. So utilitarianism names a family of consequentialist ethical theories that maximizes or endorses some kinds of utility. Now, whether utility is operationalized as number of lives saved, or maximum happiness to the greatest number of people, or well-being, the point here in all of these consequentialist perspectives is morality is located in the end rather than the principle that guides the action. So another way of thinking about consequentialism is it's the end that justifies the means. And we, of course, know of moments in history where the end did not justify the means, which is different from a character-based perspective of ethics. So here the moral focus shifts from the action, from the principle, to the actual agent themselves. So if we want to understand what constitutes a good action or a good behavior, we actually have to ask about what virtue a person is displaying. And that is bound up with how that virtue comes to pass, right? So if ultimately, a trustworthy person, or ultimately a fair person, if ultimately one who is compassionate is going to engage in morally appropriate action, or morally appropriate decision-making, we need to better understand what does it mean to be compassionate. And we can look towards compassionate qualities to guide us in our decision-making and our actions. Compared to communitarian perspectives, right? So communitarian perspectives are interesting because they dislocate or shift our understanding of what is moral to something that is potentially shared between a group of people. So a nice example of a communitarian ethics would be narrative ethics, whereby, a situation that was good, a situation that would be right, would be one which we could share in a story. If I can talk freely and openly about the happenings around a particular case that I was involved in, it ultimately must have been all right, right? But here our moral sense making isn't tied up just on the actions. It's not just tied up in the characters. It's not just tied up in the ending. It's rather in how everything holds together. And we see that in other traditions, such as relational ethics, ethics of care, even some indigenous systems of ethics as well, seem to dislocate an understanding of what is good from any individual or principle to something which is somehow shared, such as notions like reciprocity, or notions such as hospitality. Then there are contractualist perspectives to ethics. Here, that which is understood as good doesn't just exist as far as out there in some theoretical realm, but rather it is something that is negotiated between different agents, right? So when we come together and we interact with people who are other than ourselves, we make agreements with them. We obtain their consent to behave in a particular way. And our actions are ultimately judged as good or wrong, whether they live up to that contract, whether they live up to that understanding that we formed with one another. Then there's a Physiatry or pragmatic perspectives to ethics, where we don't necessarily understand ethics in terms of abstract principles, as far as outcomes that are achieved, as far as the characters involved, or even how everything kind of holds together. But rather we make sense of particular situations based on how they compare to previous cases and situations. So the ethical question or the moral question becomes, well, what's the nature of the case? What's going on here? If we previously did surgery for a baby with trisomy 18, and ultimately we said that was a good thing, then why wouldn't it be right this particular time? So we often see Physiatry enacted in jurisprudence or a health law kind of appreciation for ethics, where people look at similar situations that have happened in the past to make sense of them morally. So my reason for showing you this figure and kind of walking through them is I'm hoping to broaden your mind that I don't think one can take a simple perspective of saying something is morally right or wrong based on whether I am following this particular code, or whether I'm looking at a particular end that's achieved, because there can be different understandings of where morality is located. And we often find it very helpful to turn to these different perspectives in situations where people disagree. So we can help different healthcare professionals see a situation from a different perspective. So how do we navigate situations? Well, we navigate ethical situations through reflection and discussion. And this is something that I pointed out before, that ethics exists as a discipline precisely because the rightness and wrongness of our actions cannot simply be reduced to reasoning and calculation. Even the most systematic approaches to resolving moral ethical situations have a ground which reason alone cannot support, right? So, why is it at the end of the day that as a society, as we deal with the COVID-19 pandemic, the focus is ultimately on saving the most lives? Why is that the fundamental principle that should guide the decision making about at which point we institute triage mechanisms? Should we take another approach, one which highlights giving equitable treatment, that ultimately as a society we need to focus on equity rather than equality, right? That the focus should be on providing care to those who've been disadvantaged in the past. Would that be a more ethical response? What would that achieve? So there's different ways of looking at situations. Now, I mentioned before the Canadian Medical Association Code of Ethics and Professionalism. This is something that I ask all medical students to read, not necessarily students in this course, but if you're interested, it's only a 7-page document. It's freely available. And this is a code that gets rewritten over time and reinterpreted over time with different sections highlighted, different ones removed, recognizing that what as a society and as a profession acting with a social contract to society, what we recognize as important changes over time and gets reinterpreted over time based on reflection on events that have come to pass within the biomedical tradition. And I just left this last framework. If you were curious, you're someone who thinks really systematically, how do I work through a situation like the one Michael initially presented around the baby with trisomy 18? How do we actually deal with that in clinical practice? Well, first, we recognize that this is actually a morally ethical situation. There's value in actually stepping back and saying, you know what, there's different perspectives to this situation. So I need to begin by actually asking, what's going on here? Who's involved in this situation? What are their possible perspectives? Right? How might I understand it? Recognizing I don't want to reduce someone else's perspective as simply my own subjective grasp, right? I have to leave something open. There's value in talking to colleagues and other healthcare professionals. Why? Because they give other perspectives as well. And then we tend to begin to make explicit moral questions, like I did, coming up with that list of different questions around trisomy 18. Recognizing that we often have to clarify the language we use in articulating such questions. So if we talk about futile care, what does that actually mean to speak about an intervention as being futile, right? Does that mean it doesn't work to keep someone alive? Or does that mean it doesn't correct some underlying problem? And then we usually identify reasonable courses of action. So not actually a single course, but different possible courses. And then talking with the decision makers involved to essentially weigh out and try and work through what makes the most sense. What's the fitting response to the situation at hand? So that's practically in clinical practice, how we work through an understanding of ethics, how we work through decision making, but also how we start to make sense of and interpret and question, what kind of ethical issues are we going to see in the future? So I'm hoping from this presentation, I'm going to stop sharing now, that I'm giving you some different ways of looking at some of the really challenging material that Kim is presenting you with, the really challenging questions that he's presenting you with. Because, whether you're talking about, robots in the home, right? And what role they now play in the care of the elderly, or in companionship. I see there's a little robot dog beside Kim. Yours is probably way better behaved than my two dachshunds who you heard barking in the distance while I was presenting, or whether you're talking about, insulin pumps and surveillance technologies that parents can now use to tell whether their kids are actually controlling their diabetes appropriately or not. Whether you're talking about information sharing of data and issues around privacy and confidentiality, and at what point these are actually two different things. You need to have different ways of looking at these situations and reflecting on them to not only anticipate the moral ethical questions, but also begin to raise questions that otherwise may not be asked unless you look at it with different lenses. So I know we only have 10 minutes for questions and discussion, but we have 10 minutes.
Yeah. So I wanted to crow about something, and I think it's justifiable to do that. What I'm about to tell you was not my idea. I didn't do it, but it's new today, and it has significantly enhanced the course. So Taryn Stokowski, who's sort of like the lead teaching assistant, we have 7 TAs. What course has 7 TAs? This one has 7 TAs. Yeah, but anyway, Taryn had the idea that we would provide alternative resources so you guys can, if you wish, as an option, look at multiple points of view. So she had that idea, but we hadn't done it until today. You will find on eClass today this thing about the trolley problem and whether, the singularity university approach is good, or it's all just to sell people's books and stuff like that. You'll find a number of points of view about things, and they weren't all even suggested by me. I think some came from various TAs, and we're going to keep on doing that as of today. It's not a part of the course that you're examined on, but the other thing is, in the chat there, in the discussion on eClass, I'm not there, right? So you can speak freely, right? You can talk to the other people in the course. I think it's a really, really healthy thing. And so I'm very proud that is beginning today. And there really hasn't been this diversity of viewpoints and, the TAs finding alternative viewpoints before today. And I would like you to make use of it, but you don't have to report back to me. We're not going to examine you. We're not going to judge you for how much you used it or you didn't use it. But I think you can also bring alternative resources there, right? If you find that the point of view in this course is too much one-sided, you can bring the other side. Yeah, so it kind of expands the course in a very equitable way, where there's no compulsion for you to use this, but you can use it, and I won't really know whether you used it or not. Yeah, so I'm very happy about this, and yeah, as I say, it wasn't my idea, so I'm not looking for you to think well of me because I did this. I didn't do it, but I'm very happy that it's happened. And I think this is like the ideal day for it, because Dr. Van Manen provided so many intriguing moral questions, you have more to talk about in the course than you had before today. Yeah, so that's really what I wanted to say. Okay, so any other questions? Either from, yes, so a question from the room.
I don't know if it's a question or just a point of discussion, but in your presentation, you talked a lot, not a lot, but a bit about how like there's a historical aspect to ethics, like decisions made in the past. So I just personally, I feel like when you're encountered with a difficult situation, it's almost like the first action that you take almost sets the precedent for how you're going to act in the future. So especially with thinking about AI and possibly creating like conscious AI, if you like how we treat AI from the very beginning is going to kind of set the precedent for how we're going to do it in the future. So
yeah, I mean, another simple way to think of that is if somebody asks you why you're taking this course, the simplest answer is because it allows you to help shape the future. It's not just learning about what's going to happen, because it's not determined what's going to happen. And people just like you can help sort of move the dial, move the direction of things one way or the other. So I mean, that I think is the most maybe inspiring reason to take this course.
One of the big challenges for ethics is there's always going to be a disconnect between what is or what was and what ought to be, right? So, we can always talk about something having been done a particular way, but that doesn't equate to it being the right way to do things going forward. When I say there's like a socio-cultural, historical aspect to ethics and morality, I think ultimately health, and I would say design is the same way, or technology studies is the same way. There is a responsibility to reflect on the past in moving forward in the future. That doesn't mean repeating the same things over and over again, but it means learning from what happened. That's how principlism, so those dominant kind of articulations of respect for autonomy, non-maleficence, beneficence, justice came about. It was really in response to a number of publications of experimentation in biomedical research in the wake of World War II and in the 1970s, writings from the Belmont Report in the United States, which really heightened the need that, there needs to be these clearly accepted principles that healthcare professionals attend to in their decision-making. Now, they're articulated a little bit different in research, but you would find very similar principles articulated there. On the other hand, you could look reflectively on how we've handled the COVID-19 pandemic. And I hope someone does over the coming years to actually ask, what do we think as a society with regards to the decisions that we made? Did our principles, did our moral frameworks for working through the right way of acting actually lead us in a path that as a society we feel or felt comfortable with? Tasmin, you look like you have something to say.
Hello. This is more of like a reflection on the topics we were talking about, but going back to this view of like the history of how we developed our ethics in relation to AI, it makes me think about maybe AI would have like a potential to develop a different form of ethics than what we have, just considering I think like the Atari game or like the game mind AI, when you gave them a different way of thinking and we didn't give them the preset like history of how you should play, they came up with a different way of playing and they did it better than we did. So I wonder if like when in the future, right, AI might develop a different form of ethics that might be more, I don't know, more efficient or more applicable to modern society that doesn't reflect on the past in the same way.
Yeah. So one other thing I want to just emphasize is in 2018, I had a real surprise. I thought when we started complaining about depictions of AI in the future online, that people would ignore us, that we wouldn't have agency, that nothing would happen, right? We'd do a video and things would stay the same. Every video we created during that period, between January 2018 and June of 2019, was reacted to, pages taken down. I mean, I'm not guaranteeing that will always happen, but we were so surprised that we were able to do that. But there was nothing special about us. If you look at those videos, you could do the same thing. So that's another thing. If you're sitting here in this course thinking you don't have agency, you can't have an impact, then why study this stuff? So I'm telling you that in theory, surprisingly, you can change things. Yeah. Other questions?
I think one thing just Tasmin, in response to your comment, when you think of machine learning and how machines can potentially learn stereotypes, right? We have to be also cognizant of it may be that if we ask machines to learn and see patterns for themselves and come up with rules for action, that they may be different from the ones that we actually value. So are we going to be comfortable with that? So if machines were to look back on humanity's treatment of beings that are other to themselves or somehow different from them, and they look at humans' long-term treatment towards animals, for example, they might come up with some very interesting rules of how to treat so-called lesser beings if they were to take that as an example. And I'm saying that as a vegetarian, so you can also ignore me too.
I'm also vegan.
Yeah. Yeah, so I just want to reiterate what Rich Sutton said on Tuesday and what I was sitting there thinking. Okay, he was saying when machines are smarter than we are, they will be like our children. Think about it that way. And then later in the class, he began talking about your children do things actually that seem to be specifically to irritate you, right? They're doing things because you told them not to. And they think that's stupid. So they're going to do it anyway. And they get piercings and stuff. He was mentioning this, that just seemed to you like, why would anyone do that? Yeah, but there's another dynamic because his remarks assume that the younger the person in the family, the more unpredictable their wishes are. And in our family, that is definitely not the case. I'm the oldest person in the family, and I'm the least predictable in the family. So I think that's also worth factoring in, because what it means is that at least for a while, with sentient AI and us, sometimes the surprises will come from them, and we may not like all those surprising ideas. Just like when a child comes to you to reveal that they have a new piercing, you may not like it, right? But sometimes the new idea will come from us, the human, even though we're sort of like, the daddy or the mommy. Sometimes the shakeup will be the ideas that those people have had. And on the human side, and in some situations, the new idea that the humans have had will actually carry the day for a while. But eventually, probably all the best ideas will be from the sentient machines eventually. But so I'm gonna write a poem about that. We'll see how that goes. But I thought that was maybe the most interesting point in Rich Sutton's talk. He was kind of revealing a little bit about family dynamics. And I realize he has that's what most families are like. You know, the parents are worried about what the kids are going to do. But in my family, the kids are worried about what the father's going to do, you know, and like it's unpredictable where I am and what I'm doing at any particular time of the day. If you take any other family member, you can more easily predict where they are and what they're doing. So if you factor all that in, it makes for a really interesting future. Yeah, and a kind of active dynamic between the sentient machine providing like more beautiful ways of playing games, right? That's what's happened so far, right? And stuff like that. Yeah. So yeah, we're 6 minutes over. Anything else that you want to say? Yeah. Thank you very much for today. Go to the eClass page, look at the stuff there, you know, add things yourself. It's a really dramatic change in the course. We've been teaching this course for 10 years. We never had the kind of alternative viewpoints you will now find on that page before. And so it's an exciting moment. And I'm not there watching you. I'm not taking part in that discussion. It's sort of independent from me. Yeah, so it's really exciting. And I'm grateful. You may say, well, what's the good of having 7 TAs? I think that's it. You think of the aggregate wisdom of the 7 TAs in this course. It's like amazing, right? So that's how you ended up with what you now have on the eClass page. Michael, thank you very much for this teaching session, and we look forward to next Tuesday. And all of you have a great weekend, and thanks for your participation today. Okay, bye-bye now. Yeah.